Morning all, back to the new video. Today I'm going to discuss about a journal. This was a topic focused on paracetamol poisoning. I chose this journal because they are presented in a good way. The case report is presented in a very good way. So I just want to go for a brief discussion how a journal should be and with respect to the paracetamol poisoning. So coming to the topic, my journal discussion is about the forensic aspects of fatal intoxication involving acetaminophen, citalopram, and trazodone. So in this, we are going to discuss about focusing on paracetamol, that is acetaminophen. A brief discussion about the paracetamol poisoning, abstract of the journal, introduction that is given in the journal about paracetamol, citalopram, and trazodone. Case report, how they are presented, materials and methods they used, the results in the report, uh, and about the discussion and critical thinking part. So coming to the paracetamol poisoning, I just want to go for a brief discussion. This is made by myself. So paracetamol, it is in US, paracetamol is called as acetaminophen, derived from N-acetyl-aminophenol, and in UK it is called as paracetamol. It is derived from para-acetyl-aminophenol. So usually, like it is available in the market as over-the-counter drug. That is without prescription, it can be bought. So the poisoning most commonly takes the oral route, whereas the IV poisoning is rare because it is given under the institutional doctor's guidance. So paracetamol is a white color bitter tasting crystals on appearance. So it mainly after ingestion, absorption takes place at duodenum and jejunum. Paracetamol takes rapid absorption, that is within half an hour to 1 hour, peak plasma concentration is attained. But in case of massive overdose, it can take up to 4 hours also. So this absorption will be delayed in if the patient has taken high carbohydrate diet. So this influences the absorption. So if in case of poisoning, if the patient has taken any food, definitely the toxicity effects gonna be less because of the least absorption in increased carbohydrate diet. So after intake of paracetamol and the absorption that occurs at duodenal system, it enters the bloodstream and it goes to the hepatic uh, liver for hepatic metabolism, fast metabolism. It occurs within hepatic microsomes. It takes four pathways, that is glucuronidation, sulfation, conjugation with cysteine, and cytochrome P450 enzyme mediated and hydroxylation. So about 60% of paracetamol takes glucuronidation as metabolic detoxification pathway. About 35% takes about sulfation pathway, and 3% with conjugation with cysteine pathway, and only 1% will go for cytochrome P450 enzyme mediated metabolic pathway. Whereas in paracetamol poisoning, this 1% plays a major role. So after all this detoxification, the metabolites will be excreted through kidneys. So in this cytochrome P450 mediated detoxification produces a intermediate which is very toxic to the cells. The intermediate is NAPQ, N-acetyl-benzophenamine. This binds with the cell wall proteins and annihilates the proteins. So this leads to the structural damage to the cell wall membrane and leading to cell necrosis. Especially if this happens within the liver, so hepatocyte will go for cell necrosis. So on histopathology, can find centrilobular hepatic necrosis. So this toxic intermediate normally will be converted into inactive metabolite as mercaptopuric acid with the help of glutathione and amino acid. So any condition where the glutathione is depleted, these toxic intermediate levels will go high and they can have paracetamol toxicity. So the conditions which will deplete the glutathione stores is first obviously malnutrition, and chronic alcoholics. Obviously, they will also have decreased plasma proteins and other amino acids. And in some patients taking these drugs in anti-malarial drug, trimethoprene and sulfamethoxazole, this can reduce the glutathione and zidovudine, anti-HIV drug. Also in HIV, the patient will have malnutrition because of HIV, also because of antiviral drug, they can have this glutathione depletion. So if they take paracetamol even at therapeutic doses, they are at potential risk for developing paracetamol toxicity. So also what some in some condition the cytochrome P450 enzymes will be induced. Because of this induction, most of the paracetamol can take this metabolic pathway also. So thereby you're producing the toxic intermediate NAPQ. So which will induce a cytochrome P450 is like fasting state, and some genetic polymorphisms can induce this. Chronic alcoholic patients again can induce cytochrome 450. Isoniazid, rifampin, antitubercular drugs can induce 450. And carbamazepine and phenytoin, antipsychiatric medications, anti-epileptic medications can also induce cytochrome 450. So if any epileptic patient with a need for paracetamol, the dosage should be like in watch, because they can develop toxicity even at therapeutic doses. So, so the main culprit is this toxic intermediate NAPQ. So coming to the paracetamol poisoning proper, so the fatal dose is like around 10 to 15 grams in adults. In some books of toxicology, says it is around 20 to 25 grams. And we can have a range around like 10 to 25 grams. Some patient can have toxicity even at 10 grams, and some can have at 25 grams. So it depends on it varies with individual. So in adults, fatal dose is around 10 to 25 grams, and children they are saying like children are resistant to paracetamol poisoning because of decreased liver size ratio, thereby decrease in metabolism. So by there is decrease in production of toxic intermediate. So yeah, like it favors this thing. So but toxic dose for children also like 150 mg per kg body weight. Even a 7.5 gram of paracetamol can cause hepatotoxicity, that is liver injury. So they can develop this centrilobular hepatic necrosis. So this is about the fatal dose. Coming to the poisoning, like acute and chronic poisoning can happen. Acute, it is mostly suicidal because it is the most common OTC drug that is easily available and cheaper version, and if they take 10 tablets, it will come around 10 grams. 10 tablets of 500 mg can come around 10 grams, which is a fatal dose in some people. So, in chronic poisoning can happen when the patient is taking paracetamol in repeated supratherapeutic injection, or sometimes the mother can give wrong dose to the children. Like nowadays, it's very common. Whatever the drug that is prescribed for the elderly, they are giving to the younger child also. So because of the wrong dose calculation, the child can go for chronic poisoning. So coming to the clinical features, like metabolism, it has four pathways. Likewise, clinical features also has four stages. Stage one will last from like half an hour to 24 hours of ingestion. That is first day of ingestion. On the day of ingestion, we can tell. So the patient will have only GI symptoms. They will have anorexia, like decreased appetite. They can have vomiting. They can have sweating. Because there is decreased food intake, also because of vomiting, they can feel weak, malaise, and they can feel mild drowsiness also. In this, the symptoms would be very vague and generalized, like GI symptoms. But even lab parameters will be like almost normal only. Only there can be pH derangement, because it can go for anaerobic metabolism, where there can be acidosis, metabolic acidosis start to set in because of lactate production. So that's about the stage one. Coming to stage two, it is between 24 to 72 hours, that is second day to third day. So at this stage, we can miss the patient from diagnosing paracetamol poisoning, because it is relatively symptom-free period. So they'll be mistaken that they came back to normal. Some patients will rarely have right hypochondrial pain, like very rarely. So if they are not diagnosed at this stage, in liver parameters, LFT can show increased AST. If they missed at this stage, the patient can go for stage 3, that is hepatic stage. It lasts between 72 to 96 hours, up to 4 days. Again, the vomiting and nausea complaints will resume. Liver has two functions, metabolic and synthetic function. So mostly because of metabolic function gets affected, these symptoms starts to appear. Because bilirubin metabolism is affected, they'll develop jaundice, they can have hepatic pain, bilirubin excess of ammonia production will happen. So hepatic encephalopathy can happen. They can end up in coma. Asterixis is a classical feature of hepatic encephalopathy. That is a flapping tremor. DAC can happen, and also clotting factor synthesis will be affected. So they can go for bleeding also. The nearby structures will get affected. That is pancreatitis can happen. Renal failure happens because of acute tubular necrosis, because the metabolite takes the excretion to renal pathway. And myocardial damage will happen where myocardial necrosis is seen. So at this stage, patient can die. So this is the most crucial stage. If we miss at this stage, the patient the survival is very less. On in lab parameters, whatever that the symptoms has, that will correlate with the lab thing. So bilirubin levels should be elevated, lactate levels will be elevated because of anaerobic metabolism. Because of lactate increase, metabolic acidosis, pH will be decreased, glucose production will be decreased because of affecting the gluconeogenesis. So the patient can have hyperglycemia also, and prothrombin time will be increased because of DIC. And these two things very important classical of stage in this phosphatemia, hyperphosphatemia. More than 1.2 millimole per liter. Hyperphosphatemia is the indicator that the patient will have least rate of survival at this stage, and interleukin 6 can go downranged. So, if the patient escapes stage 3, definitely the patient will go for stage 4, that will last from 4 days to 2 weeks. So, the rule of stage 4 is all the liver function will resume to normal. So, the complete restoration of hepatic function will happen in stage 4. That's the rule. So far we discussed about the clinical features. So coming to the treatment part, if the patient present in these stages, what are the treatment we can initiate? At initial stage, if the patient presents within the day of induction, we can go for like within uh, 4 to 6 hours. We can go for gastric lavage and activated charcoal. But if you're planning for N-acetylcysteine, we cannot give uh, activated charcoal because it will bind with the NAC and minimizes its effects, and antiemetics because they can have nausea and vomiting, and supportive treatments like dextrose if the patient has hypoglycemia, vitamin K and FFP if the patient develops bleeding, mannitol if in case of cerebral edema, and broad spectrum antibiotics if they develop secondary infections. Coming to the proper treatment, that is antidotes. The three antidotes available are NAC, N-acetylcysteine, methionine, cysteamine. Cysteamine is not used nowadays. Methionine is also a oral antidote, which is a precursor of this glutathione. It increases this glutathione so that this toxic ingredient get converted into a non-toxic thing. So it is not available. Methionine is not available in India, but it is given in UK. So N-acetylcysteine is what we use here. The golden period of giving N-acetylcysteine is within 8 to 10 hours of ingestion. That if we are initiating NAC within these time limit, the patient survival rate and prognosis is very good. So what's the mechanism of NAC is it binds to this NAPQ and gets it eliminated. It reduces the NAPQ back into paracetamol, and also it enhances the glutathione synthesis so that whatever NAPQ has produced will be converted to non-toxic metabolic. So we have two types of regimens, oral and IV regimen. Oral is like NAC will have very full smell and taste, so it has to be mixed with some drinks or cola to reduce the nauseating feel. So also we will give antiemetic so that the vomiting will be prevented because of this full smelling issues. Dosage of oral regimen is like we have multiple regimens. Whatever your book says and you are following, that you can follow. In toxicology, we will be like given these doses. So the doses is like loading dose is 140 mg per kg, and the maintenance dose is 70 mg per kg every 4 hours, totally 7 doses. Maintenance dose plus one loading dose. So totally 18 dose in oral regimen. So coming to the IV regimen, we have 21-hour and 48-hour regimen. 21-hour regimen is like in first infusion, 150 mg per kg NaC is given and 200 ml of 5% dextrose. Dextrose is preferred because if they have hypoglycemia also, that can be treated. It is within 1 hour, like first infusion will be started, that is 150 mg per kg in 200 ml of 5% B. Second infusion is 50 mg per kg in 500 ml of 5% B. Third infusion is 100 mg per kg in 1 liter of 5% B. So within 21 hours, 300 mg per kg is given. So coming to 48 hours regimen, it is same as the loading dose in first hour 140 mg per kg IV is given, followed by 70 mg per kg every hourly for maximum of 12 doses is given. So this is about the treatment part. At last, we can go for liver transplant if the patient has pH less than 7.3 and pulse oxygen more than 100 seconds and creatinine level more than 3.4 mg per 100 ml. So these are the indications where we can prefer liver transplantation. So this is about the paracetamol and paracetamol poisoning. So so far we have discussed about the paracetamol poisoning. Now we are going to the topic proper, the article, I mean the journal which we are going to discuss. So I'm giving credits to the journal which I took from the Toxicology journal. It is published in Toxicology. This is PubMed Index Journal only. Like you can go for this link and check it out. So the abstract is here they are reporting a case of a young man who's a former heroin addict. He was found dead at his home by police forces in advanced state of decomposition. They have found numerous blisters and unpacked tablets of medications all over his room and the bed. And they were also noted multiple injuries to the face, left arm, and neck of the dead person. They have attributed this injuries were because of postmortem dog bites, also because they found there was no possible defense against the animal was observed. The autopsy findings were unremarkable, so they sent blood and urine for a peripheral, analysis, toxicological analysis by GCMS. It showed presence of acetaminophen, citalopram, and trazodone. So they came to a conclusion that combined drug intoxication was the cause of death. Also, they have compared this concentration with the other articles that were stating the toxic range of these. So coming to the introduction proper, as given in the article, is acetaminophen is most commonly used pain antipyretic and analgesic since 1955. It has been given for multiple conditions like headache, OA, chronic back pain, postoperative pain. It is commercially available alone or in combination. We have so many combination drugs for paracetamol. This case was presented at Italy. The disease was from Italy. So in Italy also they have OTC drug, paracetamol as OTC drug. In India also we have paracetamol as OTC drug. So the main point is paracetamol is a safe drug when administered at therapeutic doses. So when the poisoning happens, is like we have discussed about it in paracetamol point. So most commonly it is related to the suicidal intent only. Also, some paracetamol, other than antipyretic analgesics, they are using it for sleep disorders to enhance the performance of athletes, and it is mixed with drinks and water pipe and illicit drugs, as reported by this article. So coming to citalopram is a SSRI, that is selective serotonin reuptake inhibitor. It is an antidepressant drug which was given for this patient because he was on drug abuse. Also, he had major depression kind of issues, withdrawal symptoms like that. So the therapeutic dose is around 20 to 40 mg per day. The lethal concentration is at 0.5 mg per liter. As given, it is available in market, FDA approved medicine for antidepressant drug, but it is also abused as CBC medicine. They mix it with alcohol and marijuana for snorting, smoking. So these on extreme doses, they can have an ecstasy-like feeling. So the therapeutic range is like 0.7 to 1 mg per liter. Toxic concentration can vary from 1.2 to 4 mg per liter. Even the patient can end up in coma if they take more than the lethal concentration, that is 50 mg per liter. So, okay, so that's about the introduction of acetaminophen, citalopram, and trazodone. Then coming to the case report as per the article. So they have inspected the scene. So here they are reporting a case of Caucasian man, 32 years old male, found dead in his bedroom uh, by the police forces. Found by the police forces. So the intervention of law enforcement was requested by father of the deceased because they hadn't heard him for about 15 to 20 days. Initially, they were unconcerned about his silence because there was a previous family quarrel. But due to unanswered doorbell and insistent barking of dog from the apartment, the relatives alerted the fire department to inspect what was happened inside the flat. So they found the apartment door was locked from inside with the key stuck in the lock. So there was no evidence of criminal violence. The victim was found in the bedroom, dressed in shoes with upper half of the body tucked under the left side of the bed. So they found the victim dead uh, with dressed, but he was also in advanced state of decomposition. So from the information provided by law enforcement officers, they found that the person was a former heroin user. He was a drug addict. So the doctor was unaware of his addiction history. Like it has been not known how he got this paracetamol, acetaminophen, and the other drugs. But they found numerous blisters, the tablet packets with medicines all over the bed and the floor of his room. Then the forensic pathologist was called out at the scene of crime, and they also found that there was no criminal violence because there was no signs of forced entry or any injuries that suggest the criminal violence. So, but they found multiple injuries to the face, left arm, and leg. But they found out it is to be a postmortem dog bite. And the dog was found in the flat of the dead person because it is his pet dog. It has torn and fed on the soft parts of the dead body. So this is the real photo they shared in the article. It shows the person in the advanced stage of decomposition. Here we can see the mandible in state of decomposition, but the teeth are in the in his sockets. Some of the soft tissues were missing because of the dog's action. It has actually fed on him. The thing they have highlighted here with an arrow mark is presence of dog hair. That's how they have confirmed it to be a postmortem dog bite. How they confirmed it to be a postmortem bite is because there was no signs of resistance against the dog's bite found on the victim's body. So coming to the autopsy finding, that was about the inspection of the crime scene. Now they have sent it for autopsy on externally. Okay, it is an Italian male in advanced state of decomposition. On external findings, based on the putrefactive phenomena, they roughly estimated the postmortem interval range from 10 to 15 days. It is just an average range. External examination was nothing remarkable. They found the head and neck was completely skeletonized as we saw in the picture. There was no evidence of fracture or no evidence of brain injury. To conclude, it was death due to brain injury. So there was no evidence of such thing. And also there was no trauma to the lower extremities. The soft tissue part that was missing in the upper part of the body, especially on the forearm and neck, is because of the dog's action that actually fed on his body. So coming to the internal examination, they examined whatever the organs that were present at the time of inspection. Like they found there was congestion signs in the examined organs. There was, yeah, exactly. There was no fractures conveyed. There was no evidence of hemorrhage involving the brain. Also, they found the organs of the abdominal cavity was in advanced putrefaction stage, and there was no signs of trauma. Also, there was no history of pre-existing disease that could cause this death. But they found the victim was a former heroin addict. So they have sent the peripheral blood and urine specimen for toxicological analysis. What they have done is histopathology and urine blood analysis. So coming to histological findings, they have extracted sections of spleen, liver, brain, and kidneys. In the liver, they found there was cholestatic liver disease and fibrosis. Hepatocytes was altered. Like here we can see this fibrosis changes like this fibroblast. And spleen, they found there was teratological changes and decomposition changes. The capsule was regular and macrophages with the pigment like cytoplasmic granules. Histopathology of brain, they found cerebral edema, but with postmortem interval of 10 to 15 days, how they taken the section of brain is not evident. And histopathology of kidney showed glomerular and tubular shadows, pigmentocyte granules. Materials and methods they use is they have took peripheral blood at 5 ml and urine 40 ml and they stored under minus 20 degree Celsius. So they haven't used any preservatives. It's the unpreserved blood. Again, there comes a doubt like how they extracted the blood from the decomposed body. And they have used these reference from the US lab for paracetamol, citalopram, and trazodone. Then did the qualitative analysis. They also found that there was amphetamines and MDMA on the urine sample. This is just an example picture showing how they do this urine analysis of different drugs, addictive drugs. They will this is lipstick strip. So they will put the strip in the urine sample and check for the positivity or the presence of drugs in the urine sample. This is also like a immunoassay kind of thing. Here they will put the urine sample and check for the presence of multiple drugs. And they did quantitative analysis also by gas chromatography and mass spectrometry. For quantitative analysis, they use the method of selected ion monitoring. This is picture. Here there was an increased level of paracetamol, citalopram, and trazodone. Then they found like these were the results from peripheral blood. They have extracted 328 microgram per ml of acetaminophen, 2.7 kilogram, and 21 microgram of trazodone per 100 ml of blood. Urine showed around 155 microgram per ml of acetaminophen, citalopram 50, and trazodone 108. So also they did the alcohol testing with headspace gas chromatography. They also found some levels of alcohol concentration. They have correlated it is maybe due to postmortem production by the action of different species of bacteria. And the article suggesting that it will be like postmortem ethanol production. So discussion they have came to the conclusion like acetaminophen and citalopram were in the toxic level. They have compared with this study also where they have detected the levels from heart blood. This is the comparative article from which they have told like it was in final concentration. Now, from this, from his study, students et al. Study, they are telling the toxic dose of acetaminophen is between 100 to 150 microgram per ml. So, in that they have concluded there was toxic concentration of acetaminophen in this case. So they also acetaminophen citalopram was the most commonly detected drug in drug poisoning suicide cases. And Karin et al. Study suggested that even after 18 years, they have extracted, I mean, they have measured the concentration of acetaminophen in the blood specimen if it is stored under minus 20 degrees Celsius. Conclusion, they came to a conclusion that combined drug intoxication was the proposed cause of death. But from the pathological point of view, they have told like it can be due to death from acute liver failure because of synergistic action between the drugs. So far, we discussed about the journal. It's a fatal intoxication involving three drugs, acetaminophen, citalopram, and trazodone. But I had a lot of queries that this critical thinking aspect I have mentioned in this. Like the author didn't mention the adequate details from which they have arrived to the postmortem interval. That is, they have told postmortem interval is between 10 to 15 days. 10 to 15 days, the decomposed body, they don't know how, like, I don't know, like, how they took the histopathological specimens, how the organs were, they took it for H&E staining. They haven't mentioned about it, so it is very contradictory to the postmortem interval and the tests they have done. Also, they have concluded, they have mentioned that the death can be due to acute liver failure, but the histopathological findings of the liver was not correlating. They mentioned there was only changes like cholestatic fibrosis, something like that, but the histopathology picture was not suggesting of acute liver failure. So that's about the article. So this is just a general discussion about the poisoning involving paracetamol and other drugs. So far we discussed about paracetamol and poisoning effects. Thank you. I will meet you in next presentation.